Hello guys, good evening everyone. Welcome to our 5 p.m. Fundus walk. So Sunday is Fundus day. So today we are going to see some new findings on the fundus. So I hope you're excited to join the fundus session where we're going to discuss some new findings in our series which we've not dealt with in the past few weeks. So absolutely so absolutely, uh, so absolutely, so absolutely, so absolutely, okay, absolutely different. I'm so sorry for that. All right, so let's start. So I want you to first identify the site of the fundus as always, which actually I marked, but let's see. So when you look at this fundus image, yes, you are seeing this optic disc, which is nasal in location. Yeah. So this is our optic disc, which represents the intraocular portion of the optic nerve. So this is nasally located. So this is temporal. So nasal means this is the right-sided fundus because the nose is somewhere here. Yeah. So you're peeping through the pupil and you're getting this view. All right. So now I want you to first identify what I have marked as number 1 and what I have marked as number 2. So what is number 1? Is this an arteriole or a venule? 1 and 2. What is it? So this is what I want you to identify first. Yes, so we already know that we are looking at the right fundus, right-sided fundus. Yes, so what is the structure that I've marked as 1 and what is it that I've marked as 2? And you're going to tell me the structure and then we move forward to the clinical findings that I plan to teach you today. I've actually taught you this. So let's see who is coming up with the answer. And let's also find out if they are telling the correct reason why they are calling 1 and 2 as arteriole or venule or whatever. 1 and 2. Yes. So what is it that I marked as 1 and what is this that I marked as number 2? Yes, good evening guys. So we are looking at the right-sided fundus. So right-sided fundus, what is this structure that I marked as 1 and what is it that I marked as 2? Now, if you look at number 1, this red line or this red structure is quite thin. Yes, it's quite thin and it's lighter red in color. Whereas when you look at what I marked as 2 is darker red in color and a little thicker. So the one which is thinner and lighter red is your arteriole A and the one which is darker red and which is a little thicker is your venule. Okay, it's not really the vein. It's a branch or the tributary of the central retinal vein. So we actually call it a venule. So this is artery and this is vein. Is that clear? So the artery is a little thinner and the vein is a little darker. Yeah. All right. So we know that A is the arteriole and B is the venule. So therefore your arteriovenous ratio, yes, your AV ratio, A would be a little less number. So 2 and is to 3. Don't go by the number that I've written here. That is for us to identify the structures that we've marked. So the AV ratio, the normal AV ratio is around 2 is to 3. But in this case, it's a little different because this patient, the arterioles are way more attenuated than normal. So probably this is, I'll put it as 3 is to 4. Yeah. So normally it is 2 is to 3. Yes, even normally the arteriole is a little thinner than the vein. All right. So what is the finding that we're going to learn today? So I want you to see these yellow dots, yes, and this red dot, which I marked as B. So what is A and what is B? Now don't get confused with this. Okay, so that was the arteriole and the venule. Okay, so that was different. Okay, so that was different. So we are talking about this small red dot and this. Okay, what is this small red dot? What does that show? What is this question mark and what are these yellow dots? What are these yellow dots? What is this small red dot? That's a retinal hemorrhage. Okay, that's a little big hemorrhage, or you can even say it's probably a microaneurysm. We really don't know. A microaneurysm and a dot blot hemorrhages. Dot blot would be a little more like it's more blotchy. 1 second. All right, so this red dot is what I'm asking you. So this red dot, yes, very good, Satyam. So it could be a dot plot hemorrhage or a microaneurysm, which will be clearly distinguished when we look at the fundus fluorescein angiography. Yes. And what are these yellow dots? These yellow dots are very well circumscribed, very well defined. Yes, these are hard exudates. And what are hard exudates? What are hard exudates? So what I marked as A, all these small yellow dots, these are all hard exudates. Okay, so all these are hard exudates. Now this one could be a microaneurysm or a dot blot hemorrhage, as Satyam said. Now the best way to differentiate it would be on a fundus fluorescein angiography. All right, what are hard exudates, bache? All right, so let me mark it for you. So what are hard exudates? All right. So this red dot could be a microaneurysm or a dot blot hemorrhage, and these are all hard exudates. What is a hard exudate? So hard exudate is nothing but lipids and proteins leaking out of very leaky capillaries because the inner blood retinal barrier is not good. So lipids and protein exudates deposits in the outer plexiform layer, and the outer plexiform layer in the region of the macula. Isn't this the macula? Because this is the optic disc nasally located. This is the macula. So in the region of the macula, the OPL, the outer plexiform layer, is called as Henle's layer. Yes. So hard exudates are typically seen at the macula. So hard exudates are seen in Henle's layer, H for H, okay. And what is Henle's layer? Henle's layer is outer plexiform layer only at the region of macula. Just like we all have nicknames at home, only at home, okay. So there are some special names that they call you only at home, no one else calls you that way. And even your family members don't call that outside home. Okay, so it's only within home. So Henle's layer is the outer plexiform layer's other name in the region of the macula. And what are hard exudates? They look like this. Nice, well-defined, bright yellow, shiny yellow dots. Yes. These are lipids and proteins that have leaked and deposited in the outer plexiform layer. Am I making myself clear here? Yes, everyone. These are your hard exudates, HE, that I've written. So all these yellow dots, and this red dot. Yes, good Satyam. So it could be a microaneurysm or a dot blot hemorrhage, which we can differentiate very well on fundus fluorescein angiography, because this is just a red. Yes. Now on a fundus fluorescein angiography, how will a microaneurysm look like? It will light up with the dye. It will become hyperfluorescent. Yes, it will become hyperfluorescent, well-defined bright dots. Yes, well-defined bright dots on FFA. Whereas your dot blot hemorrhage will block the fluorescence. So in that area, it will not fill up with the dye because it has leaked into the extracellular space, extravascular space. So, and the blood will not leak into it, rather the dye will not leak into it, rather the blood will block the choroidal fluorescence background that we normally see in that area. So dot blot hemorrhages will appear as dark areas. You will see a dark blot there, the same red spot in that area. So this red spot, where is the red spot? Yeah. So this red spot, yeah, if it were a microaneurysm, it will appear hyperfluorescent with the fluorescein dye that we've injected. It will light up, okay, it will appear nice white or grayish white. Whereas if it were a dot blot hemorrhage, it will appear as a black spot on the FFA. Is that clear to everyone? Because there was a question once where they asked you, how does a microaneurysm appear on an FFA? It was way too much, for a NEET PG. But anyway, we should be prepared, right? So you know how to differentiate this red dots. Yes. Now, those of you who joined us late, so we have an arteriole which is lighter red in color and thinner, and a venule which is darker red and thicker. Okay, so we will see a few more where you are seeing again hard exudates and a dot blot hemorrhage. Yes, you see a lot of hard exudates. Yes, in the form of a circle. So when they are like a circle on the macula, at the macula, when they are like a circle, we call it Sarsenet retinopathy. Okay, Sarsenet retinopathy is usually seen because of hypertension. Yes, usually seen because of hypertension. Can also be seen in diabetics. Yeah. So it's nothing special. It's just hard exudates arranged in the form of a circle. Do you see the circular arrangement of the hard exudates? First of all, do you identify the hard exudates and you realize that this is the right fundus, although you can't see the optic disc per se, but I can see the optic disc here from which the vessels are coming. So this is the macula of the right fundus that you are seeing. Yes, and good evening, UK. Good evening. So you can see the hard exudates, the bright yellow, well-defined spots. What are hard exudates? That is what I marked as A. So I have not marked all of them. So all these are hard exudates. Hard exudates are lipoproteinaceous exudates or deposits in H for H in Henle's layer. Hard exudates in Henle's layer. What is Henle's layer? Henle's layer is the outer plexiform layer at the region of macula. When hard exudates are arranged in a circle, it's called as Sarsenet retinopathy. And why do you get hard exudates? Is it because of breakdown of the outer blood retinal barrier or the inner blood retinal barrier? See, in yesterday's quiz discussion, which we did, because it was a retina quiz discussion, I did explain to you about blood retinal barrier. Now, outer blood retinal barrier is at the level of RPE, retinal pigment epithelium. Inner blood retinal barrier is at the level of the retinal capillaries. The hard exudates are lipids and proteins that are leaking from the retinal capillaries. So, what do you think? Breakdown of which blood retinal barrier is resulting in hard exudates? Yes, that is a question for you. I've given you kind of all the answers. You just have to put 2 and 2 together. Yes, very good, Nima. Yes, very good. Neems. All right. Inner blood retinal barrier. Yes, very good. Okay, so there's nothing that you need to mug up. So if at all they're going to ask you hard exudates is because of breakdown of which blood retinal barrier, it would be inner blood retinal barrier. Very good, Satyam. Yes, inner blood retinal barrier. Now, outer blood retinal barrier, when it breaks down, we will have fluid in the subretinal space. Okay, where is subretinal space? Subretinal space is between the RPE, outermost layer of the retina, and the inner 9 layers of the retina. That is your neurosensory retina. So, outer blood retinal barrier would result in SRF, your subretinal fluid. Yeah. Whereas breakdown of inner blood retinal barrier is what is resulting in hard exudates. Is that clear? So, most likely this fundus is about NPDR, where we do have these microaneurysms and dot blood hemorrhages and a lot of hard exudates. In fact, this patient has diabetic macular edema because there's a lot of retinal thickening and a lot of hard exudates in the macula. We'll discuss diabetic maculopathy in another fundus walk session. But again, going back to the other fundus image that I was showing you. So please do see these red dots and the yellow dots. So when you have just red dots and yellow dots without florid new vessels, that is NPDR. Yes, and please do remember, hard exudates is not characteristic of diabetic retinopathy. It's seen in way more conditions. It's seen in a lot of conditions. But when you see microaneurysms and hard exudates, then we are kind of sure that it is diabetic retinopathy. Okay, diabetic retinopathy, because that is more common. All right. So this one is NPDR, non-proliferative diabetic retinopathy, because proliferative diabetic retinopathy means we'll have new vessels. We don't see any new vessels here. As long as you don't see new vessels, because what is the hallmark of proliferative diabetic retinopathy? That is neovascularization. As long as you don't see new vessels, it is NPDR. Yes? All right, that's good, Satyam. Good to know. All right, so one step at a time. Okay, that's slow and steady. All right, so I'm going to stop here because at 6 p.m. we're going to see you all again with the eye images decoded session. And that's lovely, Satyam. I'm happy to hear that. So I'll see you guys again at 6 p.m. So this fundus walk session, is it useful for others as well? I hope it's useful. And it's interesting, no? Every Sunday, it's like a little fun we are having with fundus. So fundus should not be a nightmare. It's rather fun doing fundus. All right? Okay. You're most welcome. Namaste ji. Bye-bye. See you at 6. You're most welcome, Neems ji.